Welcome, everyone, to our next installment in our webinar series, Private Equity Investment in Healthcare. Today, I am going to spend some time with my colleague, Chris, talking to you about state corporate practice prohibitions and fee splitting prohibitions. We're going to just have a conversation with you today about kind of what they are, where they come from, how they affect the business of healthcare. Lots of issues that hopefully will be of interest to you. Now, I think it's important to sort of level set a little bit about, why even talk about these issues. So I like to remind folks whenever I talk about healthcare in general that almost 20% of the US GDP, right, is the healthcare and life sciences industry. So healthcare as a whole makes up a massive portion of just simply the economy, the business of our country. And I couldn't tell you the exact number, but a nice piece of that number, right, is made up by the healthcare services side of healthcare, businesses that are providing care to patients, hospitals, nursing homes, home healthcare, hospices, physician practice businesses, physical therapy businesses, outpatient type businesses as well. And within that sphere, within that sort of subsector of the industry, right, you've got professional practice businesses. Let's stick with physicians. It's easier to do that. And that's sort of what Chris and I will stick to as we talk through this webinar today. You've got professional practice businesses that are, for the most part, continue to be very small businesses founded by physicians. And they are ripe for lots of the folks wanting to put money into investing in the healthcare industry. They're ripe for sort of consolidation. They're ripe for sort of bringing together into a larger whole and for trying to build and grow a larger sort of what folks think of as a platform investment in that space. Now, all well and good to say that, but there's lots of things that get in the way of how you structure those types of businesses. And most importantly, there's a fundamental issue in that, and this is what we're going to pretty much talk about today, right, is in that a non-professional generally can't own a professional business and or hire a professional. That is lots of exceptions to that. We'll talk through what that means, but as a black and white rule, right, as a macro rule, there is a prohibition on a non-professional entity or a non-professional individual, right, owning a business that professionals are employed by and or employing professionals. And we're going to talk a whole bunch about what that means and how that works. And because there's all this interest in investing in those types of businesses, often that investment ends up being on what we would call the sort of management side. And again, we'll get into what we mean by that. But again, okay. Again, some other reasons as to why we might be talking about this. Well, Chris and I probably spend every day seeing certainly more than one letter of intent where a non-professional has put terms in front of a professional that basically says, hey, we valued your business, your professional practice at $1.5 million, and we're going to buy all the equity of your professional practice, and we're going to close the deal in 30 days. To which the two of us sort of go, yeah, no, you're not, right? Like that doesn't make any sense. You can't do that. A non-professional can't acquire the equity in general of a professional practice. And so it becomes this sort of walking back, right? That walking back yes, there's a way to structure a business arrangement between non-professionals and professionals to create a business that looks like, again, I'll say looks like a whole, but the acquisition of that equity, can't be had by a non-professional. And we're really going to get into the who, what, where, and why of that. So why can't you do that? And then how do you still get pretty close to the same result in structuring deals as we walk through this webinar? So now I'm going to hand it off to Chris to just speak to what actually is the prohibition on the corporate practice of medicine.
Thank you, Ari, and thanks, folks, for joining. My name is Chris Conn. I'm an associate at Venable, and like I already said, we deal with this every day, and corporate practice prohibitions can be a thorn in folks' side, and there's probably nothing more frustrating from a business perspective than having, getting a call from Ari and hearing us say, "Hey, look, we know you agreed to these terms in your LOI, but you can't do that." And so we're here to help make sure that next time you're drafting an LOI, things are smooth sailing. And the biggest piece there is this corporate practice prohibition. And there are reasonable public policy underpinnings to why we have, I'm going to call it CPOM or CPOM, the corporate practice of medicine prohibition. And it's not, like Ari said, it's not unique to medicine. You have the corporate practice of dentistry. You have same type of thing in law and a whole lot of other, quote unquote, professional fields where you have a license to practice a certain profession. And the reason for this is if I were to form a company to start painting houses or mowing lawns, I could do that relatively easily. And if the services that I provided through that company ended up being pretty shoddy, the public at a high level is not too injured by that poor service. The same can't be said if I hung a shingle and said I could do open heart surgery or I could repair ACLs, because I am not equipped with the skill set to do either of those things. And if I advertised to prospective patients that I could, and they came into my office to get open heart surgery, only to find out that I'd never been to medical school and I couldn't navigate my way around their heart, they probably wouldn't make their way out of the office that day. And so what we want at a societal level is to ensure that folks who are advertising their services as physician services, skilled nursing services, whatever it is, that those people are equipped with the skill set, the licenses, the regulatory background to provide those services. And we're weeding out kind of snake oil salesmen. The downside of that is that you also want medical professionals, to be incentivized to grow their business and provide good care to their patients. And if they can grow a business to the nth degree, but they can't capitalize on that, then the ceiling's pretty low for them. And unsurprisingly, business folks want to be able to get involved as well. And they see healthcare services businesses as attractive opportunities. And for the reasons that Ari described earlier, these businesses are an enormous part of our GDP. They continue to grow and they continue to provide valuable prospective investments to folks. So what we often see is a workaround that we'll describe in more detail later, which is kind of a management company that provides non-professional management or administrative services to the professional practice, where the money can come in from non-professionals on the management side. And that generally, and I say generally, because there's no one size fits all solution here, that generally will work for different deal structures. Now, the frustrating piece here for lawyers sometimes and for business folks is that the corporate practice prohibitions are not they're not federal prohibitions. They don't exist at the federal government level, and they're not the same across the country. So there are going to be bodies of state law, and a little bit more complicated is they're not always found in the same place in each state's code. So in one state may have a very clear statutory corporate practice of medicine prohibition. Another state may have a more nuanced, well, it's not explicitly prohibited, but the regulations tend to suggest that it's prohibited, and the case law certainly says that it's prohibited, where another state may say their statute and their regs may be completely silent about the corporate practice prohibition, but they may have a board of medicine opinion or guidance that's explicit that non-professionals can't own a professional medical practice. And and the same thing exists for fee splitting. And the reason there is simple. It's just kind of another level of public policy concern, which is, okay, well, what if we had a physician practice that's owned entirely by a physician, but said physician splits all of his fees with non-owners? Well, that's just a facial workaround of the corporate practice prohibition. So some states will say, hey, dollars into the medical practice cannot be split with any non-professionals. And so in that situation where you have the PCMSO structure that we're going to describe a bit later, you got to pay particular attention to the fee structure. And you can't have at the end of the month, the management company gets to sweep all the fees out type arrangement. You may have to set it at a specific pegged fee, whether it's, 10,000, 50,000, 100,000, whatever it is, the fair market value of the services provided, such that you're not splitting some sort of fee splitting prohibition, and in the state's eyes, providing inappropriate incentives to to the um, to the medical practice. Um, I will say that the overwhelming majority of of states do have corporate practice prohibitions to some degree or another. Um, but there's not this one size fits all, and so each state you're going to do business in is going to have a little bit of its own flavor. Sometimes it may be the medical board that gives direction. Sometimes you may need to interface a little bit with the Secretary of State. Sometimes you don't need to do either. But making sure that you understand what what the state's specific practice prohibition is important before you make your way too far down the deal timeline, because there can be lead time items, there can be structural items that you don't want to have to backtrack on a deal. Um, of course, there are exceptions, which can further complicate things. All right, you want to talk a little bit about some of the regular exceptions
Sure.
we see?
Thanks, Chris. One of the things that's interesting, whenever we talk about this topic, whenever you get clients talking about this topic, is folks always say, "Well, I get that macro thing that you told me that physicians can't be employed by non professionals, but I don't understand. Like hospitals hire doctors, clinics hire doctors, nursing homes hire doctors. Like, how does that work, right? Like, how does that, there are definitely scenarios that, the managed care organizations hire doctors, right? There are scenarios in which non-professional entities are employing doctors, and other kinds of professional nurses and physical therapists and dentists and those kinds of things. So I don't get it. And the fact is that there's a lot of states that have either very specific exceptions or interpretations, similar to what Chris was saying about how you can find kind of corporate practice prohibitions in different states' laws. There's also exceptions that work similarly. So there's a whole bunch of states, I think Kansas and New York and I'm just thinking of ones off the top of my head, where there's either case law or some regulatory agency opinion or something that basically says, well, if you look at the licensure rules, for example, for a hospital in our state, those licensure rules say that a hospital by law is required to provide medical services. Well, as far as we're concerned, how do they do that, right? Well, they do that by employing doctors. And so they can employ doctors because they're otherwise licensed to provide that kind of professional service anyway. Um, and so there's lots of different kinds of examples like that. And going even further, by the way, there are states that, I'll use this term, essentially almost eviscerate their corporate practice prohibition by essentially saying that actually we're okay with a non-professional being employing a professional as long as, and either it could be statutory or in a case law or interpretation, as long as that non-professional does not in any way control the professional services or professional judgment of the professional. And I'll give you an interesting uh, twist about that issue. So there are many, many, many states where they enforce a corporate practice prohibition. And one of the interpretations that state uses is a pure statutory interpretation. Basically, the state says, hey, if you look at our Medical Practice Act, so the rules around who can be a doctor in our state, okay, it's pretty clear. The only way to be a doctor and to practice medicine is to have gone to medical school, have taken your exams, your board exams and your state exams, whatever it is, and be licensed. So it's pretty clear that if you read the law in our state, that you can only humans, right? Only a person that has gone to medical school and that has gotten a license can actually be a physician, right? Or provide physician services. So the interpretations that those states take is that if you're not that human that went to medical school, right, you can't be providing professional medical services, right? Um, but you then have states that say, but despite that, right, as long as the employment relationship is such that the employer is not controlling what the professional is doing professionally, well, they can be employed by non-professionals. And so there are states that actually have that either as some sort of guidance or literally a statutory reference that says, hey, you can employ doctors as long as you're not doing X, Y, Z. Texas is an interesting state where the state board has a position that it's taken for a long time that says that even hospitals can't employ doctors. They can only independently contract with doctors. And the reason they can only contract with doctors is because they shouldn't be controlling the independent judgment of the doctors. So Texas essentially says, sure, hospitals can enter into deals with doctors. We expect that, but they can only be independent contractor relationships. So there's lots of different ways in which folks apply exceptions. There's also unique things like Florida is a decent example. Florida has a licensure category that's essentially called a healthcare clinic. And healthcare clinics are basically licensed healthcare services providers. Chris and I can get together and start up a corporation and go to get a healthcare clinic license. And in getting that healthcare clinic license, there's rules around what a healthcare clinic has to do, right? There's rules around that a healthcare clinic has to have a clinical director or a medical director who's somebody who's a clinician. But then that entity can hire professionals. And Chris and I can be the owners of that entity. That's unique to Florida in some respects. I mean, there's certain states that have something similar, but pretty unique to Florida. But that's a structure in Florida that you can get to if you're investing in healthcare professional practice businesses, if you want to go down that route. That's different from the PCMSO model that Chris and I will kind of allude to a little bit as we talk anyway. But what you have to recognize about going and getting that license is that you now are subject to meeting the regulatory requirements of that license. You're inspected by the state agency that oversees that license, right? There are rules around the transfer of ownership of that license. Whereas, professional practices in general, the transfer of equity of a professional corporation or a professional limited liability company in most states is not regulated other than it has to be sold to another professional, right? And there's not, the state's not necessarily reviewing, and I say not necessarily because there's been a lot of changes in laws in certain states that we're not going to touch, but in general, the state's not, there's no pre-closing. If I'm a doctor and I own my own professional corporation, and Chris is a doctor and he's a young doctor wants to come buy my practice, okay. If I want to sell him my practice, the state is not doing some sort of pre-closing approval, right? I don't have to apply to the State Board of Medicine or anybody else to sell Chris my practice. That's generally true anywhere. However, we're in Florida and I owned a healthcare clinic license and I wasn't a professional and I wanted to sell the equity in that company to Chris, who's also not a professional. There's a licensure process a change of ownership licensure process we'd have to go through to do that. Let's flip to speak a little bit about kind of what the fee splitting prohibition is in a little bit more detail. And that is the fee splitting prohibition is funny in the way that I'll say this, it's similar but different, right? And the reason I say it's similar but different is because it has similar effects and how it can be applied, but it's different in terms of what it's doing. The corporate practice of medicine prohibition, as Chris was saying earlier, from a policy perspective, is more about trying to prohibit or control a non-professional's, pulling the strings, right, of the professional marionette, right? They don't want someone who's a non-professional being involved in or creating undue influence over a professional's decision-making. Fee-splitting prohibitions can both come into play, as Chris was alluding to before, in those scenarios, but they can also even apply to in-between professionals. So if Chris and I are both licensed dentists, okay, in New Jersey, or actually, let me change that scenario a little bit. Chris is an oral surgeon and I am a general dentist, okay? We have our own practices, but we just so happen to be in the same building. Depending on the state, let's just argue for a moment that this is Jersey. Don't take me for the fact this is New Jersey. I'm making it up. But if I have a patient and I call up Chris and I say, listen, I've got a patient that needs some oral surgery. So here's what I'll do. I know that you normally charge $2,000 for this procedure. But if I send my patient downstairs to you, you're going to give me $500 for that. And you're going to get $1,500 from the patient for the service. There are fee splitting laws that it's almost like in the nature of a kickback prohibition that essentially say, no, you cannot do that. Okay, that is a big no-no, prohibits that. Now, there are fee splitting laws, however, and it may even be the same law, that if I change those facts just slightly, will allow it. Let's say that there legitimately is $500 worth of prep dental work that a general dentist can do to his or her patient before that oral surgeon would do their work, okay? So Chris and I already have a standing agreement that says that, look, Ari's going to charge the patient $2,000 and the prep work Ari's going to do in his office. Then he's going to send the patient all loopy down to your office and you're going to do the rest of the surgery. And Ari's going to give you the $1,500 that relates to your part of the procedure, okay, or the work that needs to get done. Lots of states have no problem with that from a fee splitting prohibition perspective, right? It happens to do exactly with the facts. Now, how the fee splitting prohibition also comes up with PCMSO relationships is really what Chris was getting at earlier. I don't want to reiterate it too much, is that in the MSO PC relationship, so in the MSA, the Management Services Agreement, there's lots of states that use their fee splitting prohibitions to basically say that if you enter into a fee arrangement between the management company and the practice that's based on either some sort of percentage of the net or gross revenue of the practice, right? That is prima facie fee split, because essentially it's not that number, right, isn't necessarily based on the fair market value of the services that the management company is providing. And as a result, some amount of those dollars that are flowing between the management company and between the practice and the management company must be part of the professional fee, right? New York is sort of the most nutty on these issues. New York takes a very hard line on that. It basically says, hey, look, if you're any kind of percentage-based arrangement for management fee, clearly is fee splitting. There's no way that percentage-based arrangement could be legitimately based on the services being provided. Against that, there are other states that essentially say, as long as you've figured out that amount flowing between the two entities is fair market value, you can have a percentage-based arrangement. You can have any kind of fee structure you want. No matter what, though, the price being paid has to be fair market value for the services being provided. The other thing that I think is important to note about, two more quick things about fee splitting. One is that it is almost always statutory. There can be interpretations of how it applies, but fee splitting is statutory, and it can be statutory in two different ways. Well, technically three, but it can be statutory in that there's some sort of civil penalty associated with it. It can be statutory in the sense that it's considered to be professional misconduct for the professional. And in other ways, it can be statutory and actually carry with it criminal penalties. And there's an enormous amount of variation in how the statute is written, how it's applied state to state. And in fact, just in terms of what fee splitting prohibits state to state is probably more diverse and different state to state as the corporate practice prohibitions are. And what I mean by that is that the idea of what a corporate practice prohibition is generally the same across the states, right? And how it might be interpreted is very different, obviously, and where you find the law is very different state to state, as we were saying earlier. But fee splitting prohibitions, you can have, for example, a statutory fee splitting prohibition in a particular state that only speaks to professional to professional division of fees. So it says nothing about the issues with respect to how a management fee with a management company may be applied. And you can also have other states where fee splitting is the fee splitting statute solely relates to division of fees with non-professionals. Like they don't have anything in the statute that has anything to do with professional to professional division of fees. And or it just basically has a flat out exception that says this thing does not apply to any dollars changing hands between professionals themselves. And there's also the distinction that some states can have criminal penalties associated, some states can have civil, some states it can be just professional misconduct. Really just depends. The last point I want to put with respect to just sort of exceptions. I mean, I mentioned one exception about professional to professional exceptions where, the division of fees is appropriate. So, as I was saying, Chris is the surgeon, he gets $1,500, I get $500 from my prep work. There's another exception that many states have to fee splitting, particularly with non-professionals, that relates to legitimate marketing arrangements. A lot of states acknowledge that professionals can go out and hire a marketing company and pay them some amount of money to do marketing for them. And that's not going to be considered fee splitting, right? Now, to be clear, many of those states that have those exceptions have factual circumstances around those exceptions. So the states may say you can, marketing arrangements, are not fee splitting as long as they're not percentage-based arrangements, right? So if you get some sort of, direct mail or phone marketing type company trying to drum up a business for your practice, and every time there's a substantiation that a patient that came through them, right, used your service, you then paid the marketing company 5% or 2% or something of the fees, the professional fees that were charged to that patient. Pretty much every single state says, no, 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 that's not what we're talking about when we're talking about legitimate marketing arrangements. Um, we're talking about you're paying a marketing company, $10,000 a month to put out your Facebook ads and your Instagram ads and to make your phone calls to particular patients, but there's no one-to-one arrangement, right? There's nothing, you're not getting paid, or the marketing company is not getting paid, for every head that comes into your practice and actually becomes a patient. With that said, Chris, why don't we pivot to the sure, this is all great. So you told us what we can't do, right? And now let's pivot to the how do folks do this, right? Because pretty much I assume everybody who's listening to us today knows that there's an enormous amount of investment in professional practice businesses. And people do it somehow. And so let's pivot to kind of talking about what those common structures are and the issues that come into play.
Yeah, sure. Thanks, Ari. And I'm going to dive into what we oftentimes call the MSO PC arrangement, the PC MSO arrangement, the friendly doctor, the friendly dentist setup. They all generally mean the same thing. And to be clear at the outset, when I talk about a PC, many states, I'm talking about a professional corporation. Many states will also allow that to be a PLLC, a professional limited liability company. They may call it a professional association, but I'm generally going to call it a PC. And what I'm referring to is a professional entity, however it can be formed in a given state. The other entity, the MSO, that's the Management Services Organization, that's oftentimes going to be just a run-of-the-mill LLC that doesn't, require any sort of professional oversight or anything like that. So we're dealing with two entities that interact in some professional manner. And I think the important concept to think through here is is this idea of clinical assets. And what are clinical assets? So there are certain assets, the things that the business owns that are required by state law to be owned by the PC, by the professional practice. Those are items or contracts that are professional in nature, medical records, employment agreements with physicians, payer contracts, medications. Those types of things cannot be owned by an LLC, but they can be owned by a PC or a PLC or whatnot. Now, now the flip is not true. When we have non-professional assets, chairs that are in the waiting room, a copier, a printer, these types of paper clips, these types of things are used in professional practices and non-professional practices, but they don't need to be owned by a non-professional entity. A medical office can own both, medical records and paper clips to hold those medical records together. But an LLC can own the paper clips, but it can't own the medical records. So what you oftentimes encounter when you're looking to invest in healthcare businesses is a professional practice that owns both clinical and non-clinical assets. Now, the non-clinical assets can easily move into a non-professional entity, an LLC, but the clinical assets, those have to stay put in a professional practice. They don't have to stay put in the seller's professional practice. Maybe that's a PLLC, and you want to transfer them into a newly formed PLLC or a PC. You can do that, but you can't be transferring clinical assets into a non-clinical or a non-professional entity. So what you often see is this division of assets, whereby you have two entities, a PC and an LLC, and the PC has to provide professional services. It has to have oversight over all clinical decision making. You can't have non-medical folks in the room telling a doctor how much he or she can prescribe a patient. Um, but once this division of assets is set up, you can have a LLC that provides non-professional services to a PC. And sure, your PC is owned by, Dr. Jones, who's a licensed doctor in the state of Minnesota, and he or she has total clinical control over the entity. But dollars that come into the PC, once the malpractice insurance paid, the physician salaries are paid, the whatever medicines are need to be purchased are purchased, there may be $50,000 left in the operating account at the end of the month, and that is where the non-professionals can make their money instead of kind of the traditional route of, hey, we've got $50,000 in the company that Dr. Jones owns, and Dr. Jones can just distribute up that 50 grand. There's a management services arrangement between the PC and the MSO where the MSO is going to be entitled to a fee. Now, as I was alluding to earlier, sometimes that fee can just largely be whatever's left in the operating account. I need to phrase that the proper way to make sure it's fair market value, but sometimes it has to be a flat fee, and so you're going to kind of peg it to what we think is going to be left in the operating account at the end of each month. That $50,000 is pulled out into the MSO, and from there it can be distributed up to the investors, the non-professional investors. So the big difference here between investing in, I'm going to call it traditional or normal non-medical practices, is that your investors can be equity holders, and they can be entitled. You have four investors, and they each want a 25% cut. There's $100,000 left over. Each one's going to get $25,000. That math is pretty straightforward. But here, the money's not. It's not going vertically as I think of it. It's going horizontally. There's a contract whereby that money is I'm going to say distributed out, but it's contracted out to the LLC and then can be distributed up to the owners of the LLC. Now, this type of relationship requires admittedly more documents and more paper than a traditional maybe a purchase agreement. There are practice management documents to ensure that this works. The one that we've alluded to most frequently is a management services agreement that is going to do several things. It's going to establish the fee I just described, and it's going to establish guardrails around what the management services organization can do. So, like I said, they can't sit in the operating room and tell a clinician how much he or she can prescribe a patient. They can't do the surgery, but they can order more copier toner. They can handle the lease and pay the landlord if the medical office is not owned. They can hire the receptionist and order more paper clips. And so the business services, the management services agreement is going to really get into the weeds on what the responsibilities of the parties are. The other arrangement that I think is really, really important here is you're going to hear about it in a bunch of different ways, whether it's called a continuity agreement or an equity transfer agreement or an equity restriction agreement. What that arrangement does is it keeps the equity of the PC where it exists at the time that the transaction is done. So if Ari is a doctor and his the business is booming, and I want to invest in that business, I've agreed to go into business with Ari. Yeah, sure, he owns the PC, but at the end of each month, I'm getting some money from that PC. But I also need to kind of control what Ari can do with the 50 grand that's left over each month. Sure, I may have a contractual right to it, but Ari owns the PC. And he may say, Chris, I know you got your right, but I own the PC. And so I'm going to distribute that $50,000 to myself. Or I own the PC and it was good doing business with you, but I'm gonna sell the equity of my PC to my cousin, who's also a doctor. To which I would say, whoa, Ari, I agreed to go into business with you, but I don't know your cousin, and I want to make sure that our business relationship is staying between us. And I don't want you just distributing that money up. I paid a lot of money for your practice, and if you're going to just take money off the top, I'm never going to realize my return. Um, there are oftentimes other what I'd call more ancillary arrangements that get put into place. You're going to oftentimes see a business associate agreement to kind of cover HIPAA compliance. You're going to see sometimes a credit-like arrangement whereby if the practice goes into the red, the management company can bail it out. But an important piece here is that the management company cannot bankrupt the PC. And so what I mean by that is that if the PC traditionally has, brings $100,000 in per month, but for some reason 1 month doesn't bring in much money at all and needs to, still pay the professional practice costs, employment costs, malpractice costs, et cetera. As the business owner can't just say, yeah, well, sure, you owe me a fee. Give me my cut. Sorry, your business is going into the red. That's going to put you into non-compliance issues immediately.
I think one
I
of the
want to
things
just
that's there that's worth mentioning is that normally, I mean, certainly when we structure these things, and frankly, I've seen it everywhere, right, is that the management company looks to develop a budget, right, with the practice for its expenses so that you're hopefully never running into that issue, right? You're never running into an issue where the structure of management fee and the the taking of management fee, right, from the management company is actually going to put the practice in the red. I was actually just having this conversation with somebody the other day that about the fact that we often put in credit agreements that deal with whether or not you've got scenarios that happen where unfortunately there's dollars owed to the management company in fee, but yet they just weren't there to be paid. And the way I was describing it to somebody is I said that's sort of the document you put in place that you never want to use, right? Like you want to be sure that the way in which you're operating both the management company and the practice is such that you're not creating intercompany, loans, that and you're certainly not doing much to put the PC in the red, because then you have that's almost like prima facie indicia of a corporate practice problem, right? That clearly the practice is not operating appropriately, that it's essentially losing money because of how much it's flowing out to the management company.
I want to spend 2 minutes just talking briefly about the PC side of this right now, because it is a bit unique, and states look at the PC, who can own the PC, how the ownership of the PC works in a bunch of different ways. And for folks looking to invest in the healthcare space, you may be thinking to yourself, well, I need to form a PC. What types of things should I be on the lookout for? One is that the point Ari raised earlier, you're going to need a licensed, doctor if you're forming a medical PC in that state. That doesn't necessarily mean that each equity holder of the PC has to be a licensed doctor. Some states it does. 100% of the equity holders have to be licensed professionals in that state. Sometimes it might just be over 50%. Importantly, when you have a licensed equity holder needs to be a PC owner, that statute is going to almost certainly phrase that as a equity holder that's licensed to practice medicine in that state. And what I mean by that is in the non-medical kind of normal route, I can form a Delaware LLC and I can foreign qualify that entity very, very easily in every other jurisdiction across the country. If I am a Delaware licensed physician and I've formed a Delaware professional corporation, foreign qualifying that entity in other jurisdictions across the country can be an enormous headache because I may not be licensed in those other jurisdictions. And so I may not simply be able to be a PC owner in those other jurisdictions, let alone the issue of whether those other states would allow a foreign PC to provide professional services in those states. And this comes into play, I mean, I think in two scenarios that come to mind immediately. One is where you have a business that's working across many, many states, and oftentimes what you're going to be doing is forming a new professional corporation in each state. But also if you have a business, a professional practice with an office that's somewhere near a state border. I've got a lot of family in the Kansas City area, and professional practice in Kansas City, Missouri, may want to open a second office on the other side of town in Kansas City, Kansas, and at that point you're playing by a whole new set of rules, and it's not immediately evident that that practice can open up another office on the other side of town. Um, some states even have requirements for how you can name a professional corporation, which you might need to have the equity holder's name in it. In some states, you need to have it, PC instead of just Inc., that kind of thing. Um, so there's just lead time items that you want to think about when it comes to getting your hands around how the PC is going to be formed, who's going to be the equity holder, where the practice is going to exist, what are the business plans for expansion, those types of things. And then the last thing I'll say, because I want to leave, maybe 10 minutes or so for questions at the end, is that when you have these types of PC MSO arrangements, they um, they bring into focus certain questions about how to structure a transaction agreement. So instead of your typical, one seller entity, you're going to have a professional practice and a non-professional practice. So, well, you're going to want to think through who's making the reps and the warranties in the purchase agreement. Are all reps and warranties coming from the practice and the MSO? Who are the knowledge parties? Of course, the seller, doctor, or dentist who oversees clinical aspects of the business should kind of have knowledge of a breach. But what about the investment folks who oversee the non-professional aspects of the business? And then who's responsible for a breach? Is it going to be, are you going to exclusively point the finger at the professional doctor or the dentist, or do you have the management folks? Do they have some sort of liability? Oftentimes we see, the friendly doctor or the friendly dentist saying, look, I will happily be, the guy who stands behind the practice, but you got to indemnify me, if stuff goes wrong. And the carve out there is what Ari and I generally call the kind of bad boy acts, which is, yeah, maybe indemnification makes sense for you if there's a tax issue with the PC, or something of that nature, but we can't indemnify you for gross negligence, willful misconduct, those types of things. I'm going to pause there. I know we got about
I
10
think
minutes
that's
left.
no, we have one specific question, and you made a point before, Chris, though, that I think is worth giving a little bit more to, and that is often in the PCMSO model, folks want to brand it, right? Like the whole thing is let's build a platform and let's brand it. And you really do need to understand the PC naming rules state to state, because sometimes you can't brand it, right? The in certain states the PC can only be named the name of with the names of the professionals who are the equity holders. And so that's just something that's worth mentioning. Another quick thing worth mentioning before we jump to the question that we do have and ask for anybody else's questions is that there are many states that, in addition to having some sort of guidance, law, whatever it might be, from a corporate practice perspective or from a fee splitting perspective that relates to the management services agreement between the MSO, DSO, whatever it might be, and the professional practice. There are some states that have very specific rules, regulations, statutes, whatever it might be, that relate to management agreements, period. So it's not a oh, if you know interpret our corporate practice prohibition in this way, you shouldn't be doing X. It's actually a statute or a regulation that says that a management agreement can do A, B, and C, and it can't do X, Y, and Z. One of the examples I always throw out, because it's not even that the state has rules around the agreement, but it also requires approval, is that so North Carolina has rules around not just how your management agreement can be structured, but you can't even enter into one with a dentist without getting the dental board's approval of the agreement. Now, the other thing that I like to point out about management agreements is that there's a trend of more regulators wanting to stick their nose into management relationships right now, and on the state level, obviously. And folks should just be aware of that, whether or not states are sort of exercising their muscle, particularly the professional boards, in looking at management relationships, and and parties should understand what those states are doing before they enter into any kind of management relationship. Okay, we did get one quick question. I wanna see if we can address it, and hopefully we'll get a few others as we wrap up, as we give this time for questions. So it's a question about medical directors, and a lot of times where you have these management professional practice relationships, the management company itself looks to hire and or name a medical director, or a chief medical officer. And the question relates to, well, the relationship that that person has with the professional practice itself, right? Essentially, what's the rules around, and I'm giving this question a macro treatment. What are the rules around, what are the issues around how much that person can provide oversight, can provide guidance with respect to the practice itself? And you've got some really thorny issues, as you can imagine. You've got issues around creating potential negligence and or direct malpractice liability for the practitioner who's employed by the MSO. And as I'll give you an example, if one of the doctors at the professional practice says to the chief medical officer at the management company, I've got patient Jane Doe, and this is what's going on with her, and what do you think I should do with this patient? And the chief medical officer says, hey, I think you should be doing X, Y, or Z with that patient. Oh boy, right? You've created a scenario where you've linked the professional obligations, essentially, of, or potentially, of the chief medical officer with what's going on at the practice. That can have corporate practice implications, that can have negligence malpractice implications, can have professional misconduct implications, all kinds of things, right? And so if you were to think about a minimum issue to stay away from, right? It's unequivocally to stay away from any kind of healthcare professional who's employed at the management company, right, from being in any way directly involved in, whether it even be advice or otherwise, right, in the care of a patient at the practice that is being managed. You just don't want to create that connection. Now, more so, it's one thing to say, for example, to the professional practices, listen, we've been able, and I'm talking from the management company, right? Listen, we've been able to negotiate better pricing on this particular, ophthalmology drug, okay? And we think that it's, on average, the right drug to be used for these kinds of procedures. We've been able to negotiate good pricing on it. we'd like the managed practices, the managed ophthalmology practices to use this drug because overall, essentially, it makes us more money, right? We can use this drug. We still get paid a very high rate for the procedure that involves the drug, and so let's try to go with this drug. Now, there's a difference, obviously, between suggesting that to the professionals at the practices, right? To the ophthalmologist, basically saying, listen, we kind of like you to use this drug because here's the reasons for it. Drug still works well, show you all the research on it. We can get it for cheaper. We've got a better deal on it. We'd like to kind of stick to using this drug. There's a difference between doing that, but basically saying at the end of that conversation, but look, hey, it's up to you as to what drug you use, ultimately, but we think that this is probably the best option for us. Big difference between doing that and literally saying you must use this drug, right? That we manage your practice, we manage your dollars, and we will only allow you to purchase this drug, right? That creates all sorts of problems. It creates corporate practice problems. It creates, again, malpractice, negligence potential problems. Could create product liability problems if there's a problem with that drug in some way, right? And so there's a push and pull of what that relationship is, and my advice often to clients is to be very smart about that relationship and to not have a relationship that is probably the best word for me to use is that is dictatorial, right?
Can I piggyback on that just as
Please, please.
I don't see another question, so I just kind of hammer something home. Uh, and I want to make clear that that's not exclusive to the clinical sphere. Ari and I have encountered before um, it, investors or management company folks who generally say, "Yeah, we're going through the song and dance of forming this PC, and yeah, sure, the doctor owns the PC, but it's my company," and that's not the way you want to approach this, like because you're going to immediately run into a corporate practice issue if the management company, without the doctor even knowing it, is entering into contracts on behalf of the PC. So even when those contracts are, not clinical, they may be for staffing, receptionist, for, buying more pencils, for if the lease is held at the PC level. You can't just say, okay, we're going through the talk, but we're not going to walk the walk. If the doctor owns the PC, sure, the management company can help out the doctor, but the management company can't unilaterally run that company without your typical type of, governance approvals, those types of things.
Yep. We have probably another 60 seconds for any other questions if folks wanna jump in and ask a question. We're happy to address anything. We not seeing and or hearing more questions. I think we will wrap up. We want to thank everybody for taking the time today to listen to us and listen to this discussion of these issues. These are issues that just permeate these kinds of business structures and transactions. And Chris and I do this, in and out all day long. And there's lots of issues that surround them, obviously. You can eventually find, by the way, this a recording of this on our Venable website with all the other recordings of the prior private equity healthcare webinars that we've done, and also with a kind of a summary write-up of the webinar. So if you're interested in those, please check it out on our website. And thanks again for joining us today. Appreciate it. And Chris, appreciate you joining me too.
Thank you,
Take care,
everyone.
everybody. Thank you.